things for each case. So the first case, as you can see here, I'll let you read this for a second. So is a 64-year-old female, presents with 3-month history of right-sided loin pain, microscopic hematuria, and low-grade fever. She's been going back and forth to the GP with a presumptive diagnosis of UTI, given her background history of diabetes. But the GP is a little concerned that the symptoms haven't resolved. On clinical examination, so you see her in, let's say, A&E or acute medicine, you see that you feel a sizable blottable mass on the left side and request a CT scan of the abdomen. So you look at the CT, a CT's been done with a view of looking at the kidneys and obviously, the abdomen and pelvis, of course, and we've obtained the CT in different phases. And you can appreciate that the CT that is in front of you is an arterial phase study. And you'll also appreciate that there's quite a sizable lesion situated in the left-hand side, arising from the left kidney. You'll notice that it is quite heterogeneous in its appearance. There's peripheral enhancement with central low attenuation, kind of suggests an element of necrosis. And also in the axial cuts, you'll also notice on the arterial phase, which is here left of the image, you'll see that there's medial infiltration into the renal pelvis. And you can appreciate that on the delayed phase, where you've got contrast filtering through the kidneys, eventually into the collecting system. And you can see this lesion here, which is part of the tumor. So as you scroll through the CT, you also find that there is a suspicious looking lesion in the liver. This is the liver here, and this hypervascular lesion here. And you can appreciate the renal lesion on the opposite side. So your senior asks you what you think this is, and here are some of your options. So if I just open up the chat box, I want you guys to type in just what you think it is. Just 1 second. So yeah, just type away what you think this lesion is. So looks like it's quite an aggressive appearing lesion with local infiltration and with a suspicious lesion in the liver. So far a lot of you guys are going for A. So there's no wrong, you're not going to get in trouble for getting the wrong answer here. So just say what you think. So Luke, I noticed that you mentioned A as the option. Why do you think it's an A? Why do you think it's option A as opposed to, let's say, option B or something?
Just because it's more common, maybe. I don't really know what B specifically.
Yeah. So certainly, an RCC is one of the most common malignant renal tumors, especially in adults between the age of 50 and 70. It can have quite varied imaging appearance. It can be homogeneous or it can be heterogeneous, complicated by, hemorrhage, cysts, and necrosis, as we can appreciate on the image. The thing about RCCs, they can have local infiltration, be it to adjacent structures, but also renal vasculature is really important. So you can have tumor invading into the renal vein and then into the IVC. And this obviously has, quite significant implications with regards to prognostication. Specifically, if there's IVC involved, as opposed to just renal vein alone that's involved. An oncocytoma wouldn't have those kind of invasive features. And also an RCC, as you can see here, we've got a hypervascular met here in the liver. So a renal oncocytoma, even though it's a benign lesion, depending upon its size, it can look heterogeneous, much like this lesion. And trying to base a diagnosis on imaging alone is going to be very difficult. It's almost impossible, in fact. So in terms of most common, yes, like you said, Luke, RCC is certainly the most common malignant renal cell tumor here, but on imaging alone, it'd be very difficult to differentiate the two. Renal lymphoma, now primary renal lymphoma, particularly isolated to the kidney, without extrarenal lymphatic disease is very rare. It being unilateral and appearing like this is also unusual. Usually renal lymphomas are bilateral. They can be infiltrative or they can have focal areas of low density scattered throughout both the kidneys with extrarenal findings such as lymphadenopathy. Renal angiomyolipoma is a benign condition that contains vascular elements, muscle and fat. And certainly if it becomes greater than 4 centimeters in size, there's a risk of hemorrhage, which can complicate the imaging features. And it would be quite difficult to differentiate between that and an RCC. But this lesion, for purpose of discussion, has no fat. So we can exclude C and D. And I think through process of elimination, the vast majority have selected A, which is correct. And of course, if you're never sure, certainly you can ask your senior. So yeah, very good. And moving on to, yep, and that's an RCC. So when it comes down to sampling this, some people just may say, well, there's a mass in the kidney, just go straight to surgery and take it out. So there is an argument for getting tissue samples, be it through CT guided or ultrasound, and the choice of modality to obtain tissue samples can vary. For example, this is quite a sizable lesion situated, in the upper pole of the kidney. It's not close to any vital structures. There's no overlying bowel that's, impeding your ability to visualize the lesion on ultrasound. And it can be accessed through ultrasound. But of course, if it's a smaller lesion and if it's in a difficult location, there's vital structures in the way, then certainly CT would be more favorable. Things like patient factors also are important, for example, patient positioning, adequate breath holds, things like that. And as you can see here, this is our case with a heterogeneous renal lesion. And I also mentioned that an RCC can have quite varied appearances in that it can look homogeneous, but it can also look heterogeneous. And as you can see here in this image, you see the operator with the biopsy needle, with appropriate angulation and positioning, with the ultrasound probe, with the patient in prone position, draped, obviously skin cleaned, with the needle position centrally located within the lesion here. So yeah, so I think the choice significantly varies between operator preference and patient factors, and of course resources as well. For interest, this is a really good article, Imaging Guided Percutaneous Renal Biopsies, and it's published by the AJR. And I know many of you are obviously showing interest in radiology or interventional radiology. And if you do, if you've got upcoming taster sessions, certainly a read of this article will certainly be useful to get an overview of what happens in ultrasound guided biopsies. So this second case, so I want you to tell me which side the actual lesion is. Hopefully you didn't see the actual second slide. So same story. So this patient came in with a flank pain, and on examination you feel a mass, and you do the CT, and you're looking at the CT that's in front of you. Which side would you say the lesion is? So just type in left or right. Remember, this is the left kidney, and this is the right kidney. Okay, so someone said left, yep. Yeah, so certainly this patient did come in with, left-sided abdominal pain and discomfort. When actually, if you look at the if you look at the CT, if we were able to actually go through the CT slices, this is actually a renal cyst here. In fact, the lesion is actually situated in the lower pole of the right kidney. So this is a 2-centimeter lesion situated in the lower pole of the right kidney. And for something like this, because of its positioning, because of its size and location, we would do this under a CT guided biopsy. Now, in our department, when it comes down to focal lesions like this, we often do these under CT guidance because they can get quite difficult with regards to fully visualizing it in ultrasound and accessing it properly. And the nice thing about CT is that we can not only see the lesion in a bit more detail with regards to its proximity to vital structures, we can also make sure that the needle is actually adequately positioned centrally within the lesion. So as you can see here, this biopsy has entered the center of the lesion, angulated away from the renal hilum and also away from vital structures here, such as the right ureter. And of course, this is just less than a centimeter away from the small bowel in the upper abdomen. So that's the benefit of CT versus ultrasound. You can target smaller lesions that are going to be in slightly challenging locations, especially if close to vital structures. So both of the cases that I've shown so far have come back positive for RCC, and I usually take 3 samples, depending on the size of the lesion, of course, and fragmentation of the first 2 samples and things like that. But 3 or 4 is usually adequate. So the next patient is the theme of the septic patient, and this kind of flows nicely into theme 3 as well. So we've got a 54-year-old female with diabetes, presents with history of left loin pain, and pyrexia over 24 hours. Patient develops sepsis soon after admission and is brought to a CT scanner following appropriate resuscitation. And moving on to the patient's imaging. So this is what you see here. What do you guys think is going on here? What are your thoughts about the image? So this is largely a cystic lesion situated in the left kidney. It's a little bit complicated and it's multiloculated with thickened elements to it, as you can see here. So it does extend towards the spleen, but doesn't invade or involve the spleen itself. There's adjacent inflammatory changes here, so stranding of the fat and a bit of free fluid just around the actual kidney itself. So something like this, especially when a patient's really sick, we can get source control with regards to putting in a drain and taking out as much pus as possible. With regards to, again, CT or ultrasound, something like this can easily be accessed with ultrasound. And in terms of an ultrasound guided drain, that would require a few additional steps versus a biopsy that we would do. For example, you may place a needle with guide wire and things like that before putting in the actual pigtail drain. And of course, you can check the actual positioning of the needle with ultrasound, which is certainly a major benefit with regards to imaging modality of choice. So this is a similar case where a patient came in with loin pain, infective features. And as you can see here, this is obviously a collection next to the right kidney. Now, sometimes with regards to retroperitoneal collections, you may have, for example, a patient who may have a collection on this side, for example. And they may have really bad acute pancreatitis that has developed a collection near the pancreas, and your window of opportunity with regards to trying to get into a collection on this side can be a bit challenging, especially if you've got to kind of go between the spleen and the stomach. And certainly appropriate positioning, if the collection is on the opposite side and if you've got a distended stomach, can be challenging because, if you were to guide your needle in into the wrong direction, you could be entering the stomach as opposed to the collection itself. So that's certainly something to be aware of and to be careful about, because it's obviously, certainly quite distressing for the patient and for the team as well involved. So yeah, as you can see here, there's a collection here just next to the right kidney. And this would easily be accessed through ultrasound. And certainly this patient did have an ultrasound guided drain that was inserted. And the CT follow-up has shown that there's a significant reduction in this collection with the pigtail drain nicely centered within the collection itself. The patient was subsequently, after antibiotic therapy, felt much better and was subsequently discharged home. I think part of what I do obviously a lot of ultrasound related work and drains and things like that. And when you see patients coming into the ultrasound department, they look really sick. And obviously, that there's a source of infection. And once the drain is in and you're getting all like 200 mLs of like pus, after like 5-10 minutes or something, you actually do start to see the patient feeling better and looking better. Some of their color comes back, and it's quite rewarding when you actually when you see that. And certainly patients are really thankful for this because they do start feeling better. And they can, obviously the team can get on top of the infection. So this is obviously just comparison slide. You can see frank pus just here, and then obviously urine as an example. So theme 3 is quite similar. This is a patient that I had dealt with when I was on call. So I got called by the ICU consultant, who was really concerned about this patient that was in resus, really sick, just like, frankly septic, just no urine output, hypervolemic, and they just profoundly reduced EGFR, but they required a CT with contrast to help figure out what was going on. So just for frame of reference, this is the right kidney, and this is the renal pelvis, and you see this left kidney here, which is grossly hydronephrosis. So you've got a significantly dilated renal pelvis with dilatation of the renal calyces. And you'll also notice in this image that there are collections essentially straddled around the kidney up towards the left upper quadrant. And as I was scrolling through this, I was trying to find the spleen. I was like, oh, where's the spleen? And actually, this is the slither of splenic tissue. So the collection and the abscess, this has obviously been going on for quite some time, has essentially just eaten away the majority of the spleen, has essentially just turned it into just abscess and just infected focus. So this patient was subsequently taken to ICU. Interventional radiology got involved. Essentially, what they needed to do was they needed to put in a drain into the renal pelvis. That was part of their source control. So what they did was they did something called a percutaneous nephrostomy. And essentially what this involves is a needle into the middle or lower pole of the kidney to avoid vasculature, as you can see here highlighted in the images. A guide wire through the needle, and then ultimately a pigtail drain situated and centered within the renal pelvis. And for this patient, I believe they had, they had taken out at least like 200 mLs of just frank pus. This lady, so this is just a fluoroscopic representation of what happened. So this is just images from Radiopedia. So you can just see here, needle guide wire in and a pigtail drain situated within the renal pelvis. And this is something that you would see. And this is our patient. So this is our patient with a frank pus, with a significantly dilated renal pelvis with the pigtail situated within the renal pelvis itself. So after a couple of days, this lady did have an ultrasound guided drain put into the perirenal / perisplenic collection. And you can, after several weeks, essentially, she's had several CTs during her stay in ICU. This was one of her CTs that were done maybe after a month of her admission. And you can see here that certainly this collection of pus-filled renal pelvis is significantly smaller, and also the multiloculated collection around the kidney and kind of infiltrating on the spleen has also significantly reduced with just kind of residual changes. And this is an image just to kind of show there's not really much of the kidney left. There is a drain situated in the renal pelvis centrally, and yeah, I mean, so yeah, it's been several months now, and she is slowly recovering. You know, this was certainly quite a significant illness for her. And the nice thing also about radiology is that not only do we make the diagnosis, be it when we're on call, you know, we can further the diagnosis and management and treatment of patients by doing interventions like this that will help improve patient recovery. She did actually recently come to one of our fluoroscopy lists for a nephrostomy catheter exchange, or for a drain exchange. And it's slow recovery. Like I said, she was really, really sick with this. And, you know, this is obviously still putting out infected pus and things like that. I think a little bit of history with regards to her, I think, don't think she's a fit candidate for surgery. But certainly continuation of our care and management of her ill health and her journey is certainly quite satisfying from the radiology side of things. So in summary, we've showcased several cases with three main themes, largely overarching ultrasound and CT, and a little bit of fluoroscopy guided procedures. As you can see with the showcasing of images, that obviously radiology isn't just about reporting CTs or MRI or doing ultrasound. Certainly, there's quite a lot of hands-on approach to patient interaction, and of course, we play a central role in the diagnosis of the patients who come through, be it acutely or through MDTs and things. And certainly a continuation of treatment and management is certainly very satisfying. And some of the recommendation for reading, certainly Radiopedia is very good. You know, you just type in percutaneous, ultrasound drain or ultrasound biopsy, and certainly it'll take you to the reference page. And certainly the first article that I'd mentioned with regards to the American Journal of Radiology is a pretty good article to read if you're going to be doing taste sessions in radiology in the upcoming future. And that's the end of my talk. Thank you very much. So I'm happy to take questions. So the first question is, should the percutaneous needle be perpendicular to the skin in doing renal biopsy? So I think, again, that's quite varied. Is that on ultrasound or CT? I'm assuming one or the other. I mean, ultimately, needle positioning can vary. It depends on all kinds of things. I mean, patient positioning, whether we can get the patient in an adequate position, whether I can actually see the lesion. So yeah, I mean, needle positioning varies.
Kevin, I just had a question which I thought might be useful to go through. So when you're consenting these patients, how do you do that? Or say you're an F1 on the ward and they ask you about this, how do you kind of go about that approach? Because a lot of the time, especially as an F1, you'd be the one asked to either prep bloods or do all of that stuff.
Yeah. So the thing about consent is that when a patient comes down to the department and they've not been consented, the fact that they are now in the department, they're going to feel a lot more pressured to agree to go ahead with it versus, doing the consent on the ward with the team that the patient's familiar with. Because you obviously know these patients. For example, if you're wanting to consent a patient for image guided procedure, that we're talking about drains and biopsies, you've already met this patient and you've developed a degree of rapport where the patient feels a lot more comfortable with you. And I think, being able to take that pressure off patients and not, put them in that difficult situation when they're in the department is certainly an argument for the team consenting. Also, the team knows the patient's past medical history with regards to coagulopathy, medications, or if they're needing vitamin K, for example, or even certain factors. So incorporating all of that information and gaining the consent is certainly a lot more beneficial for the patient if it's done by the team. You also have to remember that when it comes down to a busy ultrasound list or a CT list, we may not necessarily have time to actually fully consent and fully discuss all the concerns and questions that a patient may have. Certainly we run through them and answer any questions that the patient may have before starting. But I think that reconfirmation of the consent, because the patient's had time to think about the actual procedure and whether to go ahead, and has taken the time to think. So that is that's my take on things. And I know that a lot of consultants, especially from the radiology side of things, would prefer the team. And certainly I think in our department that it's part of the policy that the team gains consent. And I'm sure it varies in different centers.
And then one other question I had about the management of these patients is, say someone's had either a renal biopsy, some other image-guided biopsy, or a drain or something like that.
Okay.
On the ward, often you're the first person to see them when they get pain around the site. Or what are the main complications of these procedures, and how should we approach them, or what do you do about them, basically?
So let me just get your question right. So your question is, the patient's had some kind of drain or a biopsy and they've developed pain.
Yeah, either pain or whatever symptom they have. Often they'll call the F1 on call on the ward, and even remembering back to my other one, I had no idea what to do. I'd often Google it.
Okay. Sure. Okay. Well, much like with anything, when you see an acute patient, obviously the ABCD approach. If, for example, it is a drain that was newly put in, making sure the drain hasn't been displaced. Obviously, if the pain can be managed with just painkillers, paracetamol, or anything stronger that is necessary and as appropriate for the patient, and if that helps with things, then certainly that would be the couple of first things to do after you've assessed the patient. But some of the main complications, like with anything, things like infection, bleeding, damage to local structures, this can involve anything with regards to injury to the liver, bowel, blood vessels, pneumothorax, and things like that. Obviously, we try and avoid things like this, but sometimes you can have challenging biopsies and drains. So, yeah. So does that answer your question?
Yeah. And I was hoping you could go through one other thing as well. So say if you see a renal mass or an abnormality, either on CT or ultrasound, could you maybe go through a systematic way of how you would think, okay, this is something weird. What am I thinking about? How do I characterize it? And how do you think, based on that assessment, what is it likely to be?
Okay. Yeah. So remember the case that I showed you with regards to the RCC? So if I went back to previous slides. Yeah, so your question is, how would I characterize this lesion on CT or ultrasound? Is that right?
Yeah, or any lesion, like how would you approach it, and what would be going through your mind? Okay,
well, certainly. Okay, well, a generic approach is, first of all, where is it located? Which part of the body is it located? Where is it coming from? What are the local structures next to it? Does it involve vasculature? Does it involve other structures, such as in this case, the renal pelvis? So that is just like a general overview of what I would do. Essentially, just kind of figure out what this lesion is, particularly where it's coming from. And then once I've kind of figured out where it's potentially coming from, I look at its, its internal characteristics. For example, this one has a varied enhancement, and the reason why I can say that is because I've seen the arterial phase and the portal venous phase. It's quite heterogeneous in its appearance, so I'd kind of just describe the lesion. It's certainly not homogeneous. I'd also look at the surrounding structures, just obviously the adjacent fat, any additional free fluid in the abdomen or in the upper quadrant here. See if this is involving the spleen and things like that, and the adrenal glands, particularly on the left-hand side, and then look at vascular involvement. So I think it depends on what lesion you're looking at, because obviously, looking at vasculature is important for a surgical perspective, for example. So I think depending upon the lesion and what organ is involved, you'd want to mention things differently. So for example, this liver lesion, like I'd want to mention what segment it is and what happens to it on the portal venous after the arterial and what happens to it on the delayed. And talk about the contour to the liver. Is there an element of cirrhosis? Could this be a met, or could it actually be a primary synchronous liver lesion? And things like that. So I think it depends on what lesion you think it is, what you're dealing with, and characterizing things further that way. And that naturally will come with time, especially once you understand the pathology, the pathogenesis of the disease, and understanding of staging and what's important when it comes down to discussion at MDT, and that you develop through your training and with experience. So I hope that answers your question.
Yeah, thank you. It doesn't look like we've got any more questions on the chat. Does everyone or does anybody have any questions that they'd like answering at all, either on renal imaging or any of the procedures that were mentioned?
Yeah, I've got a very simple question. I just wanted to ask, on the basis of images, how can, on the appearance, how can we differentiate between a mass, a cyst, a collection? So it's like heterogeneous or what?
Yeah, so the question is, how do you differentiate between a solid mass versus a cyst? So is this based on CT or ultrasound?
Yeah, on the basis of CT.
On CT, okay, fine. So if I just show you, for example, this case right here, can you see that this is quite low in attenuation and it's relatively homogeneous? There's no internal complexity to it. There's no solid components to it. Now, this is a cystic lesion. This is a renal cyst. Okay, you can measure something called a Hounsfield unit. So you can look at the density of this and it will be very similar to fluid. Okay, and as opposed to like hemorrhage, for example. So versus a solid lesion here. So this isn't necessarily cystic. There's no cystic components to it. There's a bit more soft tissue elements to this, obviously because it's a renal lesion, as you can see there. So yeah, I think it's certainly quite different on CT with regards to what is solid and what is cystic. Does that answer your question?
There's just one other question that popped up on the chat. So what was the diagnosis of the last case? Was it an infiltrating abscess?
Yeah, it was just a really, really bad abscess with pus in the collecting system, and just perirenal and perisplanchnic collection that's just infiltrated just into the local structures and just destroyed the spleen essentially. So I think this lady did have long-standing renal problems. think they had like PUJ stenosis and, with a background history of diabetes and things like that, and just recurrent infections involving that kidney, obviously with time has just resulted in this kind of pus forming just collection. That was quite complex. So yeah.
So I think we're done with the clinical questions. We've just got a question on the chat asking you what your favorite part of your job is.
Okay. Oh, my favorite part of the job. Okay. So I think so several things really. I mean, I think radiology, you can shape radiology in any way you like, really. There's obviously the academic side of things. There's the scope for really progressing in whatever field or subspecialty you choose, kind of pushing the boundaries, and you can kind of shape it any way you like. I mean, obviously I quite like a lot of procedure stuff, but what I like is the continuation of patient care. For example, like I said, I can make the diagnosis if I'm on call. Then the next day I'm doing the procedure on the same patient that I've reported the CT on. There might be the liver lesion that requires characterization with regards to liver MR, and okay, we might need to do a biopsy of the liver lesion, or we might need to discuss it at MDT. And I think because you get to play quite a central role with regards to the patient's journey, you also get to know the clinical team quite well, and not just like the juniors, like to consultant level. I speak to a lot of the hepatobiliary surgeons on a weekly basis with the MDT that I do, and I think kind of developing that clinical rapport with the seniors in other clinical specialities is certainly quite rewarding, because when you're on call and it's a busy on call and they call you and they can completely understand and empathize with you. So you definitely feel in radiology that there's a sense of kind of togetherness, I suppose, working as a team, as a wider team for the patients. And also, I mean, the radiology department is a pretty relaxed group of individuals. And yeah, so there's lots of things, and there's lots of things that I like about my job that I find satisfying. But I think the combination of furthering the diagnosis and being central to patients' treatment and management is really important to me. Hope that answers your question.
Great, thanks. Yeah, so it looks like we're all done with the questions.
Yeah, great.
Okay, so thank you for coming, everybody. Do you have a few words to say, Luke?
Yeah, I just want to say thank you, Dr. Phillips, for taking the time out this evening and presenting. And
welcome, my pleasure.
I hope everyone found it very interesting, and I certainly learned many things this evening. So I would hope you would all join us next week for another one with Dr. Phillips, and we're going to be looking at keeping the theme of renal, and we're going to focus on nuclear medicine and some more of the alternative imaging modalities and procedures next week. Thank you.
Thank you, everyone.